for making the time. We are so excited to be here with you. I want to briefly introduce the members of the team. So again, I'm Emily Marchese. I'm the Executive Director of Reach Out and Read. I'm also joined by our full tiny but mighty team. So we have Jessie Lizio, who is our Senior Manager of Medical Engagement. She is your point person really for all things related to medical engagement. And part of her wonderful team is, of course, Veronica Hitchen, who I'm sure her name is familiar to many of you in your inboxes. She's our program coordinator of medical engagement, so she's a resource for you as well in terms of scheduling site visits, help with progress reports, anything that you might need in terms of those logistics. We're also joined by Sejal Kathari, who's our senior manager of books and literacy. Sejal runs all things books. So if you have questions about the book order or the surveys or any of those logistics, she's your point of contact for those matters. And then we also have our wonderful development team and our newest team members, Megan and Jack. They are also resources to all of you if you have questions about fundraising or anything pertaining to book donations. We are all here as a resource to you. So regardless of whether or not it's a question that you would normally ask Jessie or Veronica, know that the whole team, we're all here to support you in gratitude for all of the hard work that you do for our community. So this is our team. There's 6 of us, and we are all here with you this afternoon, and we're really excited to dig into our agenda. Couple of housekeeping notes. This session is going to be recorded, and then it will also be available to you on YouTube. Please do use the chat throughout our town hall today. So if you have questions or comments, feedback, anything like that, please feel free to put that into the chat. We will be monitoring it. And then when there's Q&A as the town hall progresses, we'll make sure to go back to those questions and address them as best we can. Any questions that I can answer now, or we ready to dig in? Okay, wonderful. Well, thank you again for joining us, and we're so excited to get into our town hall today.
Good morning, everyone. So this is just going to be a really brief, under 3-minute presentation on our book needs. So just a little refresh. Many of you are familiar with the annual survey that we used to have. Some of you who are new may not be, and we're always happy to answer any questions. We're going to be sending that out in October. We're going to do a 6-month survey instead of every year so we can get a more accurate gauge on how your needs are on the ground. It's going to be collecting integral information for effective tracking of site contacts and shipping information. The book needs and preferences as mentioned, your storage capacity so we don't flood you, and training needs and volunteer opportunities from the medical engagement team. This is a working link with our updated version of the survey. If any of you are extra ambitious and would like to get a head start, you can click the link there. And just a public service announcement, we really need you guys to complete the survey as soon as possible once you receive it. We're already allocating books based on the need data we have in my ROR for upcoming deliveries and orders, but we want to make sure that that is in line with what you're actually seeing at your clinics and sites. And also, please note, we really cannot guarantee book need requests without less than 2 months notice. We never want to say no to anyone for books, and we will do our best to make sure that that scenario doesn't happen. But we do need lead time in terms of working with the publishers and submitting orders. And then that is the time that they need to actually get us the quantities that we need. Next slide, please. Thank you. And so just for a little bit more of the exciting updates to come, a book for every child is our goal and our mission. And it's an actual goal, but also a teaser about our fall benefit, which is coming up from our development team next. Book Buddies, as many of you are familiar with, the shipments from the spring 2023 order will arrive November and December. So sites that are allocated to get those books can be expecting them soon. I will update everyone with track notices as soon as I receive them from the publisher. So just keep an eye on your inbox for that. Fall Book Buddies is underway in the planning stage now. We're going to be focusing on Haitian, French, Arabic, Bengali, and Mandarin books, all bilingual, to also make sure we're covering those in addition to Spanish. First book shipments, which was another coalition we participated in, will arrive November to December. Again, all sites will receive tracking info. And again, just notice that it's essential for us to have strong, timely communication regarding all orders, as with the additional notes below. And if you have any questions, don't hesitate to reach out. We're always happy to help. Thank you so much.
Hi, everybody. I'm Megan Fair. I'm the new Senior Development Manager here at Reach Out and Read of Greater New York. I'll keep this short and sweet. Our fall benefit is coming up really quickly. It's around the corner, a little less than 2 weeks away. A book for every child will be Thursday, October 12th. It'll be at the Edison Ballroom in New York City. We do have tickets available for purchase as well as table sponsorships. If any of your organizations are interested in supporting in that way, we would of course love to see you there. We also have a special form that we've created for our medical professionals exclusively for complimentary tickets. And so those will be doled out, so to speak, on a first come, first served basis. We will start assigning those tickets next week. The link is here in the presentation, but I'm going to share it here in the chat again for everyone. So just in case you haven't put in your request yet for those free tickets and you'd like to join us for cocktails and a seated dinner and award ceremony, which is honoring our amazing medical professionals who do this incredible work for all of us, we would love to see you all there. So please get in those requests as soon as you can. And other than that, we look forward to seeing you hopefully at the fall benefit, and of course honoring you if any of our honorees are on this call. I think I saw Yuli on this call. I'm sure there are others. So we're thrilled. So thank you for your support. It means everything. And the goal is obviously to help provide a book for every child. So we'll have all the funds will go toward providing more books for our clinics, and with a special emphasis on those diverse titles, those culturally reflective stories, and particularly the dual language needs, as Sejal mentioned. And that's it.
Me?
Yeah.
From where?
We're all done with the benefits. So sorry. I'm getting some feedback that I didn't
Who
know
did?
if you were chiming in.
Could
But we
everyone
can move
go
on
Yeah.
to the next slide.
Yes.
Sorry, if everyone could go on mute, that would be you.
If everyone can please be sure to mute. Thank you.
All right,
Okay.
everyone. Hello, my name is Jack Downs. I'm the development coordinator for Reach Out and Read of Greater New York. So I wanted to quickly plug our newsletter. So Reach Out and Read is so excited to share our new quarterly newsletter. These are going to be coming out on a quarterly basis. And that is because they have all of the information that you could ever need. We are trying to see the newsletter as a bridge between what we're doing at ROR GNY to you medical professionals and community members. And so it's very much worth the read. It has a lot of impact statements about what ROR is doing based off research models. We have updates from every single department, like books, development, medical engagement. We highlight some of our sites. And so if you're ever interested in that, please reach out to the medical engagement team. And we even give book recommendations. And it's a kind of one-stop shop for everything you need to know about Reach Out and Read of Greater New York. Our first newsletter went out back in September. So please check your inbox for that if you have not already seen it. Unfortunately, sometimes it can make its way into the junk mail. So check that too. Be sure that you can read it because it has tons of good information, and be on the lookout for our next one coming up in a few weeks.
And as many of you know, we are currently wrapping up our July 2023 progress report cycle. This is the second of our biannual reports that occur in January and in July of each calendar year. The reports are tremendously valuable for the ROR team. The data that we collect helps us with book procurement and distribution, identifying language needs based on patient demographics, and providing information to donors to secure funding. The current report launched in July, and the hard deadline is this Sunday, October 1st, after which we cannot accept any more submissions. So today is a great chance to double check my ROR, make sure you have that report in. And if you have any questions, please contact me or Jesse. Throughout this reporting period, the medical engagement team has held office hour sessions for sites to pop in, ask any questions, and get any support that they need. As of today, we have an 87% completion rate for the July 2023 report. And looking ahead, the next report cycle will launch in January of 2024, and we hope to reach 100% submission. A big thank you from our team to all of you who have taken out the time of your busy schedules to submit the report. We greatly appreciate it.
Thank you so much, Veronica. Moving next, the next couple of slides, we're gonna discuss the importance of following the Reach Out and Read program to fidelity at your site. Big shout out to Elmhurst Hospital. We took this picture back in January when doing a resident training with Dr. Wolliver. Wonderful. If you haven't already, you should be receiving an email soon from the medical engagement team to schedule site visits in person or virtually. Some of the criteria that we're currently looking for to see at your site for the site quality classification is percentage of book distribution, percentage of providers being trained in Reach Out and Read, accurate representation of providers listed as contacts in my ROR, a rich literacy waiting room area, and of course, providing early literacy guidance during the well-child visit. I wanted to thank the sites for allowing us to take these wonderful pictures, and this allows to, whenever doing town halls or presentations like this, we can give you guys examples of what we're looking for and what we'd love to see in sites that are thriving with Reach Out and Read. So of course, we want to see the books being locked in a safe place and locked cabinet or closet. And of course, if the site has availability and space for the books to be in either the examination room or right outside the examination room, for the books to be labeled by age and language for easy accessibility for the medical providers to take a book right before the well-child visit. Also, we advise you to, in order to track books accurately, to use either electronic medical records, or we've seen sites using tally sheets or even stickers. So we encourage you to use a system that is best for the site in order to accurately track the books, as we need this to accurately provide books to your site. Wonderful. When we're talking about a literacy rich waiting room area, we're mindful that every site is different. However, for those sites that allow it, we love to see posters that promote literacy, posters or flyers sharing community resources for the families, such as adult literacy programs, library information, quick tips for the parents to read at home. And we love to see too murals or interactive posters so that we're applying early relational health throughout the well-child visit, even before, during, throughout the well-child visit, so that caregivers can interact with the child at all times, talking about the bright colors they see in the wall, or counting, like the animals, or anything that allows them to connect and bond right before the well-child visit. Last but not least, we are working on a list of resources for you guys. We can send those right after the town hall. We are providing them whenever we're going to the site visit. We give you guys a list of a very detailed email with all of the resources that we've discussed during the site visit. And one of my favorite one-pagers is the program quality self-assessment, so the site can take a look at what the site is actively doing to see if they're championing Reach Out and Read at their site. If you have any questions, I encourage you to use the chat option. And if you have any further questions, please feel free to email us at any time, and we're more than happy to assist.
And so to move into our wonderful presentation, we have Dr. Olison with us today. She is a dually board certified in internal medicine and pediatrics, and has practiced transitional medicine for vulnerable populations with a focus on performance improvement initiatives throughout her career. She is a fellow of the American Academy of Pediatrics, the American College of Physicians, the American Board of Quality Assurance and Utilization Review Physicians, and the New York Academy of Medicine. In each career chapter, according to Dr. Olson, one of the most fulfilling aspects has been the development of patient and person-centered processes to enhance engagement and leverage technology as it evolves to deliver superior clinical outcomes. Please join me in welcoming Dr. Olson.
Oh. Thank you, Veronica. That's a very flattering presentation. And I'm really privileged to be able to have the opportunity to speak with everyone today. I've had the professional privilege of practicing for 37 years, and I've been retired for 28 days from Care for the Homeless, where Reach Out and Read was one of our most appreciated programs in the pediatric component of the family sites and open access sites. What I'm going to talk about today is adverse childhood experiences, the ACEs, resilience, and how Reach Out and Read is a point of effective intervention to build resilience. Next slide, please. The objectives are to understand the correlation between adverse childhood events and lifelong health outcomes, review in detail the epidemiology of the ACEs, identify strategies which translate science into active programming, which create a stable foundation for healthy lives, and present evidence-based resilience contributors as frontline interventions to address the ACE impact on children. Next slide, please. Why Reach Out and Read and ACEs? Reach Out and Read began with the idea that doctors have a special opportunity to encourage reading aloud in families that are facing the dual challenges of poverty and limited literacy, and that the educational connectivity is indivisible. The National Academy of Medicine report highlights that the duration of education is a better predictor of health and long life than either cigarette smoking or obesity. And moving forward, there have been obviously disparities in health and in education. And many of these disparities have been significantly exacerbated in the past 4 years with the pandemic. And we have seen unfortunate outcomes because of it. Next slide, please. And the good news is that a very recent evidence-based study of over 100,000 Reach Out and Read participants, which was published in June of 2023, reinforced the positive impact that exposure to Reach Out and Read has on children and families that have participated in the program. It's a multi-year study. The national nonprofits model effectively encourages parents and caregivers to read with their young children, actively promoting parent-child bonding and connection. It builds on previous evidence that families who participate in Reach Out and Read are more likely to have books in their household, more likely to read, and that the children have improved language development by 3 to 6 months. And this is incredibly important, as we'll see, looking at some of the ACE issues and indicators. Most significantly, additional information that came out in January that needs further study is saying that there has been a limited but demonstrated correlation between increased screen exposure between birth and 18 months with decreased executive function by 9 years of age. So that really exposure to books and interaction is becoming more and more critical. Next slide. Reach Out and Read has been demonstrated to be the most studied and scaled primary prevention program. And it impacts more than 25% of all children in low-income families by improving language skills and increasing reading aloud activities. Next slide. So what is the Adverse Childhood Experience Study? Of late, ACEs have become part of the nomenclature of social drivers and determinants of health. This is the largest study of its kind, and it looked at health and social effects of childhood experiences over a lifespan. And it was done, next slide, in 1998 in California. And it was a collaborative effort between the CDC and Kaiser Permanente, over 17,000 Kaiser patients. These are not individuals who were indigent. They were adult patients, interestingly and significantly, who had dealt with lifelong obesity and some of the secondary sequelae. And what it revealed is, as adults, they were able to hearken back to their childhood experience, and then much of the subsequent literature that came from this really changed the whole lens through which primary care practitioners can view adults who have been the victims of ACEs, and unfortunately, childhood ACE experiences can translate too often into adult trauma, and as we'll see, lifespan negative health and mental health impacts. Next slide. So the ACE findings revealed that of the 17,000 respondents, more than 25% grew up in a household with an alcoholic or drug user. 25% had been beaten as children. 2/3 had one adverse child event, and 1 in 6 people had 4 or more ACEs. And what becomes evident in the study is that the impact, negative impact on the individual, increases with the number of experiences of adversity that they experience. Next slide. And this is really the true nature of pediatric preventive medicine and public health. The travesty and the tragedy of this is that the childhood adversity, which we'll enumerate in terms of the types of categories that are included, results in disrupted neurodevelopment, social, emotional, and cognitive impairment in early childhood. In adolescence, adoption of health risk behaviors, early sexual contact, increased sexually transmitted infection acquisition, substance use disorder, alcohol use disorder, in alcoholism, and in early adulthood disease, hypertension, diabetes, and behavioral health conditions, abuse and being abused, and then early death. You know, in my previous position, I had worked at Care for the Homeless, and what we saw, the tragedy of people who had experienced chronic homelessness died up to 15 years earlier than domiciled peers. We did not have a large Medicare population. This is a real tragedy. And again, the pandemic has only made these impacts that much more obvious statistically and clinically. Next slide. So the ACE categories that contribute to the ACE score include emotional abuse, physical abuse, sexual abuse, neglect, both emotional and physical, and then a household in which the mother was treated violently, household substance abuse, household mental illness, parental separation, and incarceration of a household member. And the overlap and addition of each of these has an unfortunately synergistic effect on the overall outcomes for the individual experiencing them. Next category. Next slide. Now, this overlaps somewhat with the social determinants of health, which have come into focus and have been largely neglected in diagnoses of individuals. So there are ICD-10 diagnostic categories that don't exactly overlap with adverse childhood experiences, but can be contributing factors, so that really the ability to be attentive and record these as part of a history is important. As we'll see, some of the screening for childhood adversity is controversial and problematic from a overall trust perspective, and is in the evolution process. Next slide. The screening for ACEs. There are multiple tools one of the, again, tragic realities of screening for ACEs is that very often the parents may have themselves been subjected to multiple ACEs, and then it is an intergenerational condition. And so when the screening with questions to the parent brings out information from the parental perspective, the examining provider can have a higher index of suspicion that there is childhood adversity occurring in the home. The Pearl screening tool is another pediatric tool that's been introduced, recent HRSA-based TASY initiative introduced this tool to see how it can work in primary care practices. Next slide. And one of the things that has been highlighted is that you know, a sensitive history can open the door to discussion about in-home adversity, but it needs to be balanced with security and trust that this does not turn into immediately a referral to Child Protective Services, which can be a reason for not having the screening be as universal or as accepted. And the other issue is that very often the situations change over time, and how this can be incorporated into a medical record most effectively is something that's being evaluated with different types of screening tools. Next slide. So the original experience of the ACE study showed the breakdown as outlined here, with a very high proportion of individuals exposed to alcohol abuse and mental illness, drug abuse, and then the childhood psychological abuse. And as we'll see, next slide, please. That the exposure in childhood is translated across adolescence and adulthood to significant negative health and mental health outcomes in adulthood. And really the approach from a provider's perspective is the need for accessibility and availability of the supportive resources beyond a physician's office for effective intervention on many levels. But again, it's an awareness of where people's conditions have evolved from. Very often was an unfortunate early onset exposure. Next slide. Now, these slides can be very discouraging, although they tell a story. And the rates of maltreatment by age, this was from 2014, and really and tragically, it demonstrates that the youngest children have the highest proportion of maltreatment, mostly from neglect. And the neglect creates emotional and medical conditions that are long lasting. Next slide. And that the adversity impairs development in the first 3 years. Now, again, this is showing the number of ACE risk factors and the number of children with developmental delays. And again, this graphic linear relationship is what is seen throughout all of the adverse childhood experience data, is that the increased adversity is associated with a predictable linear increase in developmental abnormality. Next slide. And then what happens over time? In childhood, it's a developmental delay, school expulsion. It can also be missed vision and hearing deficits, lack of well child follow-up, immunization delays, and lack of early intervention for the developmental delays because of this. In adolescence, it contributes to delinquency, mental health, sexual activity, drugs and alcohol, experimentation, and violence. And in adulthood, psychiatric and behavioral health diagnoses, drug abuse, alcohol use disorder, crime, and then also metabolic diseases because of poor lifestyle choices, particularly early smoking and poor dietary choices. Next slide. And again, what are these associated health problems? Progressing from childhood with developmental delays into adulthood with chronic obstructive pulmonary disease, depression, ischemic heart disease, unintended pregnancies, early pregnancy, risk for intimate partner violence, alcohol abuse and addiction, sexually transmitted disease, smoking, suicide attempts, severe depression. Next slide. And the propensity for these progressive ACE scores leading to negative lifespan health and behavioral health outcomes is again statistically impressive for something that can be addressed and perhaps prevented. Compared to individuals with no adverse childhood experiences, individuals with 4 or more ACEs were twice as likely to smoke, 7 times more likely to have alcohol use disorder, 6 times as likely to have had sex before age 15, twice as likely to have cancer or heart disease, 12 times more likely to have attempted suicide. And men with 6 or more ACEs were 46 more times to have injected drugs than men with no history of ACEs. And these are, from a population health perspective, really devastating, predictable outcomes. Next slide. So you could say, well, this is really all very, very negative. And what's next? The very hopeful and good information is about plasticity, neuroplasticity. And just as there is early neurotoxicity, there is plasticity and repair, which is remarkable in children and is retained through adolescence and even into adulthood. And the presence of plasticity and repair is really the hope for treatment and intervention for adversity, and then really prevention of lifelong trauma impacting individuals' lives. Next slide. So stress, we all know that there's stress and there's stress, and the toxic stress is the stress that is not constructive for healthy living. Next slide. It can also be, stress can be positive, tolerable, and toxic. And noticing and identifying children who have toxic stress exposure is not always easy. Certainly coming to a health center could be a stressful moment for many children, so that exactly getting a read on their affect is not always the easiest thing to do. Next slide. How the ACEs work. Again, this is really that the childhood adversity feeds into the development with neurobiologic, psychosocial, and health risk behaviors that then result in long-term consequences, as we've outlined, with disease and disability and social problems. And the disease and disability include major depression, suicide, and post-traumatic stress disorder, drug and alcohol use disorders, and intergenerational transmission of abuse, as well as situations such as homelessness, criminal behavior, unemployment, parenting problems, and ultimately the shortened lifespan, which is the biggest tragedy of the entire ACE pyramid, really. Next slide. So toxic stress response occurs when there's a constant alert, even when there's no immediate threat of harm. And it can disrupt the development of brain architecture and other organ systems and increase the risk for stress-related disease and cognitive impairment. And this can occur and continue into adult years and is a similar characteristic of what has been described in post-traumatic stress disorder. Next slide. And what are responses to stress from a behavioral perspective? Children can have excessive guilt or shame. They can constantly perseverate in retelling of a stressful situation, have extreme feelings of fear, sadness, or preoccupation and worrying about seemingly small events. They can have sleep disturbances, difficulty concentrating, difficulty learning, and ultimately poor school performance, complain of stomach aches and headaches, and engage in reckless or aggressive behaviors. Next slide. In adolescence, this progresses and there's a self-consciousness, withdrawal from family and friends, and a radical shifting in the way they think about the world, not a hopeful, prospective, looking forward to their future approach, but really becoming incredibly isolated and negative in their view of the world, and engaging in self-destructive or accident-prone behaviors. Next slide. Now, United Hospital Systems did a study in 2020 at the height of the COVID epidemic between March and July, and it evaluated the then impact of the pandemic on children in New York State under the age of 18. And their findings revealed that there were long-lasting racially disparate impacts who lost a parent at that point in time, or were pushed into poverty because of either becoming an orphan from loss of both parents or loss of one parental income. At that point, which was premature in the pandemic, 4,200 children had lost a parent because of the pandemic, and 325,000 at that time were in poverty or near poverty who had not been prior to the impact of COVID-19 in March of 2020. Next slide. And what this study revealed was what are the long-term considerations of the pandemic impact in terms of education, with the need for distance learning, the discrepancies and disparities in access to effective distance learning, children in poverty, the mental health needs of children that had been being addressed in person in school. And additional ACEs, 20% reported an increase in substance abuse among patients, families, and individuals who were already struggling with an antecedent substance use disorder and overall life disruptions. So then what was done, next slide, please, was this was quantified. And this is devastating in terms of the cost that the pandemic will have. And it's also underestimated at this point because of the impact beyond the acute phase of the pandemic. But adverse childhood experiences in the immediate pandemic period costing $13 million a year for the next 60 years, life disruptions, teen unemployment, huge cost because of this. And it's going to be a cost that's going to be needed to support the children that were most impacted during the height of the COVID-19 pandemic, because many of these adversities and disparities that have been identified or have not totally been resolved, and there are many subsequent sequelae that still need to be addressed. Next slide, please.
Oye, de ambos.
So some of these are the CDC data about the ACE score and the risk of being a victim of domestic violence. And this is, again, where this is also painfully predictable from, and the reason for having an effective approach to intervention is so incredibly critical, that men and women, between having no ACE exposure and greater than 5, will have an increased risk of being a victim of domestic violence, as well as, next slide, please, increased propensity for perpetrating domestic violence. And that's the intergenerational travesty of childhood adversity. And again, you can see that it is painfully predictable in a linear fashion. Next slide, please. Childhood experiences in chronic depression. And this is in childhood ages up to age 19, women versus men, adversity on the bottom. And again, the percent of people with a lifetime history of depression increases with the increased exposure as a child to adverse circumstances. Next slide, please. And chronic disease, similarly, ischemic heart disease, stroke, chronic obstructive pulmonary disease, diabetes, and then, as previously mentioned, the sexually transmitted disease, dramatic increase, particularly in men, with increased numbers of ACEs. Next slide. And mental health diagnoses, similarly, mood disorders, anxiety, substance abuse, and impulse control disorders are all predictable with increased adversity and adulthood trauma, because the lifestyle rolls from childhood adversity into traumatic lifestyle and repeat trauma of adult proportions. Next slide. And ACEs cross generations. And this is kind of the aggregate story of what happens with an initial individual with child abuse and having the school problems, depression, aggression, going from adolescence and dropping out with substance abuse, PTSD, re-victimization, and then as an adult, parenting problems, domestic violence, poverty. And then, unfortunately, the second generation child becomes the victim of the same. Next slide. From my own experience as a collaborating physician, basically this is sort of an illustration of what can happen in a situation. And I received a phone call really about a poor weight gain in a 5-month-old baby who was very low birth weight and had a heart murmur. And just in talking through the case, it became clear that there was a 21-month-old sibling. The mother herself had severe depression, PTSD, was a victim of childhood sexual abuse. Her brother was 15 years old, had anger issues, and the matriarch of the family was 43 years old and herself had severe depression and multiple chronic illnesses. Next slide. So this is, as it is not an all negative, hopeless situation. It is a hopeful opportunity. ACEs are the most preventable cause of serious mental illness and preventable causes of drug and alcohol abuse in women and HIV high-risk behavior. And they are a significant contributor to lifestyle choices resulting in comorbid conditions and death, heart disease, cancer, stroke, and diabetes. Next slide. You can address the toxic stress component because that really is the missing link between ACE exposure and poor adult outcomes. What needs to be identified are ways to treat, mitigate, limit, and immunize against the effects of toxic stress. So, the immunization phenomenon is really a social immunization. Next slide. And what can be done to help to identify children at risk? Motivational interviewing techniques, a list of local resources for the practice, handouts about childhood adversity and positive parenting, and really, active promotion of positive parenting for young children, which is as constructive for the young parent as for the child. Promotion and support of protective factors and family strengths, and involvement of a social worker, case manager, care coordinator for the family in the practice. And obviously all practices don't have the resources to have all of these on-site resources, and frequent visits for children who could be at socially high risk for adversity is a way to build a positive relationship, where the view is not only you come to a health center to get a shot as a baby, but you have a relationship that is constructive and meaningful for the parent and the child, and can have an impact. Next slide, please. So, what is being done? A lot of things. The Universal Primary Prevention, Bright Futures, Reach Out and Read is at the top of the list. Connected Kids, Quality Early Education. The screening for risks is certainly a piece that needs to be part of a well child examination. Just as, in the old days, you had a Denver developmental, and now it's become far more sophisticated in terms of, social, cognitive, mechanical, motor acquisition development. And the risk for adversity needs to be something that is included in all assessments. And then evidence-based treatments. Next slide, please. The good news is that the proven treatments exist for traumatized children, and the trauma-focused cognitive behavioral therapy, child-parent psychotherapy, and parent-child interactive therapy are all evidence-based to be effective and as effective for children with 4 or more adverse childhood experiences as for children with 0 to 1. Now that is really very compelling information, so that it is something that when identified and addressed early on, this can be a life changer and a lifesaver. Therapists have to have the training, follow the guidelines to get the best results, as in all manners of clinical treatment, and that the treatments can improve the children and the parents' mental health outcomes. And it appears to restore normal biology and stress response systems with the best outcomes. All of this is extremely positive. Next slide. The resiliency model of prevention, social immunization against lifespan trauma. It's a very ambitious model about resilience is the ability individuals have to remain healthy even in the presence of risk factors. And it prevents, resilience does, long-term adverse consequences by buffering with stable, responsive relationships. And resilience helps children to develop a sense of safety and restore their stress response to a baseline, as opposed to having it on high alert constantly, which causes the ongoing trauma and damage. Next slide. Protective factors for resilience, safe, cohesive neighborhood, needs being met, connecting with a stable adult, safe home. Not all of which can be provided through a health center or a physician's office. However, the connection with a caring, stable adult can certainly be established, and affording access through entitlement, enrollment, and engagement and frequent visitation are things that an office can provide for a family. And we do. I think that the safety net, and that's a huge piece of what many offices provide for many patients for many years. Next slide. So Reach Out and Read works and is a resilience builder. And participating families have demonstrated in over 20 peer-reviewed studies that the families are 2.5 times more likely to read with their infants, toddlers, and preschooler children, twice as likely to read 3 times a week, and again, twice as likely for families to have reading become a shared activity in the home. And the bonding. I think the piece here also is that literacy is a huge disparity, and books should not be viewed as barriers at all. And certainly the books for younger children, where there's the ability of the parent to make up the story, and that it's the spoken word and the musicality of voice as much as the printed word later on that encourages the bonding. And children's language ability improves with increased exposure to Reach Out and Read. And a lot of that is actively encouraging the engagement between the parent and the child, and using the book as the intermediary device. Next slide, please. And Reach Out and Read has an intergenerational success. It shows that the 2-generational approach improves parental attitudes and practices, changes the family schedule with their in their weekly reading as a shared activity, and sharing books with children and making reading one of the child's favorite activities. As well as the participating families demonstrating higher attendance for well child visits. And fascinating, at the end of from birth to 5, the child would really have a library. And if they have a brother or a sister, they would have a library too. And so families that participate are more likely to own 10 or more children's books. I know from my own experience that the children loved getting a book. And it was far more constructive than, stickers, which were a lot enjoyed, but I guess I was opposed to lollipops of any sort from early in my career. And very often that, a child receiving a book would come to hand it back to me and thank me. And I'd say, no, that's yours. You can have it. And it was very clear that having a new book that was theirs was a unique experience, and that's heartrending, heartwarming, and very encouraging. And frequently, I also was asked, "Can I bring one home for my brother as well?" And so we bring your brother down, and we'll be happy to give them a book. Next slide, please. And this is Kofi Annan, who had been the UN Secretary General, said, "There's no trust more sacred than the one the world holds with children. There's no duty more important than ensuring that their rights are respected, their welfare is protected, their lives are free from fear and want, and that they grow up in peace." It's very well said, and thank you for your attention, and really would be interested in any comments or questions that you have. There are a lot of attached resources, and I think they'll all be made available to you for through the portal.
Thank you so much, Dr. Olasin, for such a powerful presentation. Yes, we'll like to open it for questions. So we're running out of time, and we want to be mindful. We had scheduled for until 1 p.m., but I think we could stay here for an additional 5 minutes in case that you have questions for Dr. Olasin. And as a reminder, this thank you so much, Dr. Jackson. Any questions that you may have for Dr. Lassen at this time? Or for the Reach Out and Read team?
Or comments too, because I'm sure that everyone on the call has had extensive experience in seeing, dealing, and realizing the heartbreak of childhood adversity.
I'm checking the chat as well, and everybody's saying thank you so much for this town hall meeting and the presentation. So this is wonderful. And as a reminder, everything is being recorded and will be posted in our YouTube channel. We're going to be sharing the resources that Dr. Lassen has collected for us. And I think this is very wonderful. Again, Dr. Lassen, thank you so much for your time and your powerful presentation. This was very enlightening, as many have said.
Thank you to everyone for what you all do every day, and how Reach Out and Read can help us all do a very difficult job for the most vulnerable who deserve it the most. Thank you. Have a wonderful weekend. Bye-bye.
Have a great weekend, everybody. Take care. Bye-bye.